Hello, and thanks for joining this episode of Healthcare Digest. I'm Doug Barry, a principal in the Mazars Healthcare Consulting team. In this episode, I'll share some insights around the end of the COVID-19 public health emergency and the potential short and long-term implications for healthcare organizations. We'll look at everything from staffing to digital strategy to additional government reforms related to providing telehealth care and hospital at-home care. So for hospitals, historically, they tend to play catch up. They're not out in front of regulatory changes. So I believe this is going to have some short-term and long-term impacts that are going to catch providers by surprise. I think one of the most dominant and scary things for certain geographies would be the fact that there's going to be a 20% reduction in Medicare payments. So while that may not be significant to a metropolitan area that doesn't have a lot of retirees, can you imagine if you live in Palm Springs or Orlando, Florida, where 50 to 60% of your patients have Medicare? That's a significant financial hit. You know, when you talk about telehealth, we here at Mazars are constantly asking our clients to try to walk in the shoes of their patient, see things from their patient's perspective. And I think a lot of patients are challenged to accept telehealth as a treatment and to start to pull away from that long-standing physical physician relationship they've enjoyed. I find that there are opportunities to be seen quicker, but I'm not convinced that clinically you're going to be able to get equitable care. The people who like telehealth the most are the payers. I think they're already struggling. The typical emergency room is impacted by the nursing shortage, just as the med-surg units and the rest of the hospital. So patient throughput has been challenging through the pandemic. And there's been long waits and patients sitting in the emergency room for up to 18 hours, just waiting to be seen in some locations. So it's been very challenging. I imagine an influx of additional patients because the typical Medicaid and Medi-Cal patient can't see a physician if they're uninsured. They're going to go back to what we saw pre-pandemic and pre-health emergency, and they use emergency rooms as their primary care source. And that bogs down nursing and physician staff with low severity of illness cases to treat. And it means that those that are more severe are going to be waiting longer for care. I mean, to move patients through the process when there's an influx of low severity cases, it complicates the entire movement through discharge. So I think hospitals are not prepared for an influx of patients, and I think it's going to be impactful with overall patient satisfaction. It's not just the clinical piece too, if you think about it. We start at the beginning of the process. As we enter that facility, we have to speak with someone in registration. We have to provide information. That typically is streamlined when the insurance is involved, but if you're not insured, those discussions take much longer to work through the initial stage of the visit. And registrars are not advocates, and the people who help with financial screening to help patients seek whether it's charitable sources, charity care within the institution, or outside resources that could help compensate some of the bill they're going to generate. Those people take much as 10 to 15 minutes in those discussions. So imagine if you have hundreds of patients coming in to use the emergency room as their primary care, and each one of them bogging down a registrar for 15 to 20 minutes each, where today you can work through that process in about 6 minutes. So it's going to mean your lobbies are filled with people waiting to register. There'll be more complaints. The physicians and nurses are constantly frustrated with front-end line staff when that happens and patients are moving slowly. So you can anticipate this impacting the overall aesthetics of your visit. So I think you'll see on the surveys that people receive in the mail, how was your experience? I think you're going to start to see those scores that are so important to senior leaders start to slide. Access is everything in my mind, and I think I've seen several of our clients recently investing to improve the whole self-registration patient portal experience so that the public can, once they present, quickly move into the clinical aspect of their visit. So having as many patients shift to pre-registration, online registration before they actually hit the ground and come to the institution, I think that's going to help a great deal from a resource perspective, from a patient satisfaction and the wait times, also in terms of ED throughput, because you won't have the log jam that happens when they all present and that there's no data captured. So I think having a strong patient portal to get access, as well as the technology for the scheduling with medical groups, there's more movement towards AI technology that can backfill canceled appointments with similar diagnoses, that can monitor patients that choose specific days of the week that they go to their doctor, so that if that opens up an appointment, they can reach out to the patients that are more likely to agree to come in early because of the day of the week. There's a lot of sophisticated technology now that is really focused on making sure that physicians and appointments are optimized and that they're filled and that cancellations are accounted for and rescheduled. And it's all about access and not having resources that aren't being utilized in an efficient manner. I would say that they're not prepared. One of the things we do frequently in our practice here at Mazars is evaluate those work streams for clients, and it's amazing to me that it's the one piece of business that actually pays gross charges, where insurers pay much less than gross charges, and yet it gets the least amount of attention. On the flip side, I believe someone paying 100% of gross charges deserves the most attention. So what we're seeing in the industry, of course, is there's always been an emphasis on trying to collect money up front. But for this population we're talking about, that's not really the case because they're flowing through the emergency department. These aren't scheduled services where there's a time and place to have that dialogue. They're emergent services because they're showing up at an emergency room regardless of the severity of illness. So you're going to see a whole lot more uninsured patients and statements that are required and collection activity that are required to address that population might not be in place, because these shifts in volume are going to mean either you have to add additional collectors or you have to pay additional cost. You're not budgeting the cost of multiple statements for an enormous amount of increased population. And if you have a vendor relationship, frequently the cost of that service to provide the billing and collection activity for self-pay was based on the volume of accounts at the time of the contract. And there may be language in that if you suddenly change the placement volume and activity and expectations that they're going to be able to effectively work that, it may change the terms of your agreement because you're asking the vendor to add resources. Or if they don't add resources, you're going to see a decline in productivity and a decline in performance. I think, well, they may not need to be revised. They certainly need to be revisited, because I think that that calculation and what hospitals anticipate writing off, it's a moving target. It changes with shifts in payer mix, and this would be a very typical shift to self-pay. So most hospitals are conservative, but there are those that are using what they use as reserves to sort of manipulate monthly profit based on over reserving, under reserving. It's a financial approach that is different and that some CFOs are aggressive with, some are not. But at the end of the day, if I'm anticipating a number of patients on a monthly basis to be uninsured and uncollected and going to bad debt or to a collection agency, that number is going to grow simply because the number of patients that may not pay me is going to grow just based on the volume of new business that's rolling off the Medicaid enrollment. And remember, for a hospital self-pay program, it's one thing when you have balances after insurance and employed individuals, regardless of income. It's another thing when you have people who qualify for Medicaid that are poor and already struggling to pay rent and other bills, and to expect them to pay. They're not going to pay. The majority of those patients will end up in bad debt. So those reserves will need to be looked at to see if you took too conservative of approach. You may need to add additional cushion for what we believe is going to be an increase in bad debt. That concludes our conversation in this episode of the Mazars Healthcare Digest. I hope you found it informative. I have included my contact information. Please don't hesitate to reach out if you have any questions or would like to discuss how your organization may be impacted by the end of the public health emergency. Thanks again for listening.